We're going to get, any minute, it has to make up its mind to come back slowly. Uh-oh, we've got the box down at the bottom again. Ah, good. Okay. Let's fast forward to where we were. Okay. I think this is about where we were. Now, it turns out, see, with all this difficulty breathing, and we're going to show you in a minute exactly what COPD is in some lung pictures, that's bad enough that you're coughing and you got a lot of mucus and you're having trouble breathing. But then every once in a while there are these terrible exacerbations, as they're called, where you're really in a bad way for a few days. At least if they don't count it as an exacerbation or getting worse temporarily unless it's at least 48 hours. Most of those, not all, are due to an infection. Well, see, we all know intuitively that if you break the skin anywhere and you're not careful about cleaning it, every bacteria in the South County tries to jump in there and you get what's termed a secondary infection. The infection didn't cause the break in the skin, they just took advantage of it. Now, if you've got a break in the lungs, remember, see, you're wide open. We breathe this air and we don't think about it, but nobody sterilizes that air for us, so there's all kinds of stuff circulating around. How come we don't just die of lung infections right off? Well, we have a tremendous amount of immune system there, see. Actually, if you look at the other tube, you see, actually you could look at a human being like we are alive between the skin and this tube that goes through the middle. Now, the gut tube, something like the majority of all of your immune system is in the gut. That may sound strange, but you remember everything that's going through there, you better be prepared to meet it. And to some extent, the situation is exactly the same for the lungs. And we know, oh yeah, that's right, there's good gut bacteria. Well, there actually is in the lungs too, but nobody makes much of it. You never hear about that part. But if you are damaging the lungs, you are opening up spaces that aren't supposed to be there, you're a little bit more inclined to infection, and probably your immune system is down from this whole thing happening to you in the first place. So you're not exactly surprised to find out that these exacerbations seem to correspond largely to infections, but they aren't all, and we'll see in a few minutes what they are. Unfortunately, there is still sort of an argument, if you want to call it that way academically, that the various interventions that one can do presumably to make the symptoms of COPD better, oh no. Okay. That it's not really settled whether, let's go forward in time now. Now going back to this will be real quick. We went through this before. I'm just going to focus now on these ends out here because, see, if you think about the diagram, we've given you this nice airflow and so on, and then what's the magic that happens down in the lungs? How do you get the oxygen? So we're going to focus on the ends of these along in here. Those terminal bronchioles end in these little pods, and if you sort of slice one open and look at it, there are these little globular sections. They're called alveoli, and it is the walls of these little sacs that actually suck up the oxygen. Now, that's a lousy diagram, so let's go to one a little bit better. Okay, you see here in the healthy diagram, here are these nice little alveolar sacs. And if we look over here, this guy's got pneumonia. There's a lot of watery stuff and mucus in these. It's like trying to breathe underwater. You've all tried that when we were very young, and it doesn't work very well. And so this guy is really in discomfort. Now, the guy with COPD, now we're using the term emphysema here because remember, that's what you call the damage. COPD is a condition. So we're seeing down here that the little sacs are being damaged, the cell walls are getting smaller and so on, and there's just less surface area to absorb oxygen. Now, So in a normal situation, we see the bronchioles coming down here into the alveolar sacs, and there they all are, and they're just sucking up oxygen like mad. And when your red blood cells go through the lungs, you're sitting oxygen down on the hemoglobin in them, the heart's pumping it out to the rest of the cells in the body that don't have lungs of their own. They get the oxygen, everything is living happily ever after. Now, let's look at the one who's got COPD. Now, in that case, the first thing you see up here is the bronchioles are shrunken, they're losing their shape, they're becoming clogged with mucus, and damage is happening out here in the alveoli. The walls are being destroyed into bigger looking things, and less surface area and less oxygen is being absorbed. So it's a bad thing, and that's what I'm talking about. Physical damage, or the technical term is architectural change. The other one looked kind of pretty, and this looks like a mess. So one can avoid COPD by simply reducing the causes, not smoking, improving indoor and outdoor air quality. But see, these don't deal with the progression. That's more or less a prevention thing. Or maybe if one did have COPD, you'd maybe breathe better with good air than bad. But what do they do if one's really got it? Now, why would they give vaccinations? Well, if they can keep you from getting some of those infections, that would be a good idea to begin with. Pulmonary rehab is just working the lung tissue better. Various bronchodilators, yes, there are inhaled drugs that will relax them and open them out. And of course, if somebody's really bad off, there's oxygen and even lung transplants. So we're talking really wicked treatments here. So in those periods of acute worsening, sometimes if they're really bad off, they have to go to the hospital. You will see in a minute the case history of one guy who almost did. We'll show it to you. Worldwide, it affects about 5% of everybody. That's a pretty big percentage. This is a world map which is done this way. The darker reddish places are the places with more COPD. So what you're looking at over here is India. In the north of there, it's very dark, and the tip of this up there, but then you see you come off to these slightly less colored areas, and there's the United States. So we're having trouble with it, but what's the deal over here? Well, it's indoor cooking fires, they think. You're inhaling all this stuff right in the house all the time that you're in there. Now, interestingly, Canada is considerably much less. I don't know whether that's being Canadian or whether they just have nicer air. I've never met a Canadian I didn't like, but I suppose there are some. So obviously there are three goals about this. Don't get it or find it early. Relieve symptoms. That is not too hard. Decrease progression. That's a lot harder because they're not admitting that they really know how to do that yet. We're going to be talking about that. But here's the slide I told you about. If you've got a friend who smokes, for goodness sakes, please explain to them that if they don't get lung cancer from that and they live long enough and continue to smoke, they will get COPD. And those are just two of the nasties that smoking will do to people. So if you really like these people, go tell them to change their ways. Now, what can we do about it? Well, aside from watching what we're breathing, let's talk about this thing called chronic bronchitis. Okay, bronchi tells you where it is. Itis tells you it's inflamed. Well, we know that could be done from infection. It could be due to a respiratory allergy. But these things could slowly foster COPD. So if there is any long-term shortness of breath, get a spirometry check. Now, see, we're thinking about, suppose somebody gets respiratory crud, and they've got a lot of mucus and they're having tough breathing. Am I really terribly excited they've got COPD? No. But if they get cured up from the infection and they're not getting over the breathing problem, that's when I would go get a spirometry check. We'll see exactly what that is in a minute. If there was mild COPD, we'd consult a pulmonary specialist. That's a good idea because they evaluate very carefully. But they chiefly use pharmaceuticals for symptom invention, and there's a whole lot of chemistry to do with this that they don't seem to consider as much as I would like them to. Now, that is a very high-class clothespin that you see there. probably costs an amazing amount of money. We don't use it on our equipment because we found that the people can just hold their nose themselves. We learned to do that when we were quite small. What's that for? Well, see, since what you're trying to measure in this are several things, like if they take a deep breath and blow out as much air as they can, the machine down here measures exactly what the volume of that is, and you're holding this just in case they're losing any air out the nose, that's all. I've never seen this before. I saw this picture when I hunted for a picture for you. So that's basically what the spirometry is. It can also measure how fast you can empty a certain amount of air, which tells you whether those little things are closed off to some extent and you can't get much air through them. That's one of the things about asthma, is that they usually have trouble breathing out more than they have trouble breathing in. Now, what's the mechanism? What causes the progression? Well, okay, there's several destructive factors that they've located, but it gets to be sort of a chicken and egg picture, like which one of them caused which. Now, in medicine, I've been convinced for a long time that we have one of these domino effects where one problem falls on two, falls on four, and pretty soon the person is messed up or covered with dominoes. And so obviously, if you keep the first things from happening, the rest of them don't. And but recent thinking now calls COPD a progressive immune disorder. Okay, progressive again, meaning it's going to keep on after the original insult. Somehow it's rolling along, but now we've gotten the immune system in it. Well, see, inhaled chemical causes cell injury, which causes immune generation of defense molecules that actually do tissue damage. After all, the defense molecules are supposed to be killing bugs or something. But it also happens to be accompanied by invasion of the lung tissue by immune cells, which can do further damage than just defense molecules. And see, the inflammation continues for years after the chemical exposure is no longer there. That's the progressive aspect, which we hate. Now, what is called a feed-forward cycle occurs. The original damage causes inflammation, which causes damage, which causes inflammation, and that's what we're talking about. It feeds off of itself going forward. And you may not have thought about this, but there is no inflammation without the immune system. It all comes from the immune system. Now, in my business, we distinguish between what we call inflammatory chemistry, which can be going on and nothing is swollen or inflamed that you can see or feel. Well, see, usually in supposed defense, immunity generates oxidants and free radicals to counter various bug invaders or something like that. And those molecules can damage tissue, but we repair from that if we just got a bad cold or a little bronchitis or something. If the situation gets out of control, as in COPD with a feed-forward cycle, a lot greater damage occurs and continues. But see, theoretically at least, oxidants and radicals can be subdued by antioxidants. This strategy has been amazingly little explored for COPD, but I'll show you an example. Before we get there, see, both oxidants and reducers of inflammation might help break that cycle. Fortunately, a number of possible treatments do both of these things. And we'll talk about some of the agents that are under investigation, but they don't do us a lot of good in the here and now. Thank you. There's an amino acid that we use called cysteine. That's not very well absorbed. If they attach this little piece to it, it is absorbed, and nobody wants to go around all the time saying N-acetylcysteine, so they just say NAC. That turns out to have an active part of the molecule very similar to the glutathione that we make. In fact, glutathione is 3 amino acids hooked together, and one of them is cysteine, and that is the one with the action. We'll show it to you in a minute. Now, there's been a report that it helps COPD when taken orally. I think that came out in 2005. There was another paper came out in 2014 that says, no, it didn't. So you don't know who to believe. Here are two perfectly reputable places, and you have to examine the papers very carefully and try to figure this out. Now, the trick here is orally, because it has been known for years that inhaled NAC mist helps some symptoms of COPD. It'll get the mucus out and stuff like that. So it appears that we either need the agent onto the lungs or have it better absorbed. See, like NAC is much better absorbed than glutathione. Now, this is the kind of device they use for inhaling this. It literally, you put the liquid solution in it containing what you want, and it just blows it into a little mist, and you inhale that. Now, let's talk about nebulized glutathione. Nebulized meaning it's misted. You don't have to pay any attention to this, but this is the cysteine part right here, and that little sulfur hydrogen group is where the action is. So here's a scenario. This really happened at Tahoma Clinic. In 1997, a 95-year-old man was wheeled into my office in a wheelchair with an oxygen tank by his much younger granddaughter. I was quickly informed that while he had oxygen at home and didn't use it, this was our wheelchair and our oxygen. The nurse at the front door took one look at him and stuffed him into the chair because he looked pretty bad. Now, it was confessed that he had been diagnosed with emphysema from COPD, and that he'd gotten a recent bronchial infection, and that had caused the greatly increased difficulty breathing. Now, at that point, he said, "Don't send me to the hospital." Now, I teased him and asked him if the food was that bad, and he said, "I'll die there." And I explained to him that it would take an insane doctor not to send a 95-year-old man with trouble breathing to the hospital, but he was very persuasive. So we agreed not to send him on 3 conditions. Did he have an immune-enhancing IV? That's a little 10-minute IV invented in the 1930s with very dilute hydrochloric acid. It's one of the best immediate stimuli for the immune system. It's operating in an hour, if not less than that, and it's good for 3 days, and it will even lick some of the worst bacteria there are because it's doing it with your own immune system. It's not killing the bacteria. The hydrochloric acid you put in disappears like that, but what it does in the meanwhile is trigger the system to get itself together to meet whatever challenge is there. And that he inhaled glutathione mist twice daily. Now, at that time, the only glutathione in the clinic was in the IV room in bottles about that big, and so I went and grabbed one of them and said, "You know you have COPD. By any chance, do you have a nebulizer?" "Oh, yeah, never use it, but I got it." So we taught him how to inhale this, and then I absolutely insisted that somebody in the family called a daily report to me about how he was doing, because, as I said, I thought he belonged in the hospital, but he might have been right, that he might have died there. Well, every day I got a report, he's okay. Third day he walked in, no wheelchair, no oxygen, said, "It worked." Well, I thought that was marvelous, but then he said, "Actually, I'm breathing better than I did before I had any trouble. Is it okay if I continue the glutathione?" "Absolutely." Well, you see, that caused me to think about the whole thing. How did I know to give him the glutathione in the beginning? I am an ex-research chemist turned physician, and I get fascinated with molecules. And so one day I was looking at the glutathione thing, saying, "That's an interesting little molecule. Let's learn all about that." Now, it turns out, remember, you know this, that when they want to study some medical condition or something about the way the body works, since it's kind of illegal to use people for that, they go out and try to find the closest animal model, either doing the same chemistry as people or having the same disease as people, and then they work on them to figure out how to help it or why it's happening or something. Now, it turns out the nearest, I won't say animal, I'll say thing, that mimics what's called the intermediate metabolism, the intermediate chemistry that occurs inside a human being, is that of a mosquito. I cannot imagine how many mosquitoes they must have had to do their experiments with. But anyway, they determined all about how we make glutathione. It works. They've checked it out. It's true. But they originally determined it all with respect to how the chemical worked in mosquitoes. Well, I was reading all this mosquito chemistry and saw that while it's manufactured in every cell, we make a great deal of it in the liver, and it's exported and imported onto the lungs. And then I'm going, right. It's an antioxidant. It's there to keep you from being oxidized. And so when the guy walked in, I happened to be studying this and just went, I got an idea. Let's try to beat the infection and let's see if this will relieve your breathing. Well, it turned out at that point, since it did, I thought, well, is he the only person in the world that this is going to work on? So him and then 5 more people, making 6, were the next 6 people that came in with COPD. I would try the inhalation of glutathione on, but I would sort of cheat. I would give them a freebie in the clinic and then say, go out and call back here in 2 days and tell us what happened. Now, of the 6, 5 of them said marvelously better, but it didn't last. And so what we did then was place a prescription so that they could get the glutathione ampules and put it in their atomizer and breathe it. Now, slowly over the years, I have seen the price of those little ampules from the compounding pharmacy increase in cost up to an obscene level, which was worrying me because I don't like highly expensive medicine. And then a new patient walked into me having COPD, and in the course of deciding what else we could do for her, it turned out she was inhaling glutathione. And I said, oh, who prescribed that for you? Nobody. I just started taking it. I said, well, where'd you get it? It's a prescription. Oh, no, there's this company that puts it out in capsules, and I just opened one of those in some water in my nebulizer, and I'm going, I got to find this company. So we stock this downstairs now, see, that you take the capsule under directions as to exactly how to do it, and it now costs pennies to do a treatment, see. So I am so glad that accident. See, never let it be said. Doctors do learn from their patients.
What's the name of it? Is it just called glutathione? What's the name of the capsule?
I don't know. They would know downstairs. So we published this story in 2000. Now, it's called Use of Nebulized Glutathione in the Treatment of Emphysema. There's sort of a funny story. We didn't think it was funny at the time about that. Now, Matt Brignall was a postdoctoral research associate with me. He had graduated from medical school and looking for a job, but I knew he was very research-oriented, so I said, how would you like to do research for a year while you try to figure out where you're going to practice? And he said, right. And he got very excited about this case that I asked him to write it up. I gave him the data, and I said, write it up, I want to look at it. So we tweaked it into a paper to submit to a journal. And I had in mind that it would be sent to what was called Alternative Medicine Review. And he was so excited about it, he wanted to send it to the top British journal, Lancet. And I said, well, I have my doubts as to whether they'll accept it, but give it a fling. Well, Lancet, being properly British, were very polite about turning it down. They said that they got about 3,000 of these case histories a year and were very sorry that they could not publish them all. So we didn't feel too bad about that. So then he sent it off to a respiratory journal. There were 2 of them, actually. One was called Respiratory Medicine and one was called Chest. I don't remember which one was first, but the second one disparaged our degrees while they turned it down. And anyway, in the meantime, he and I had published 7 scientific reports, which are all in the National Library of Medicine that year. And his term was up, and he was down, and he said, what are we going to do with this paper? And I said, why don't we send it to Alternative Medicine Review like we were going to? And we did, and it's published there, and you can pull it down if you know how to go to PubMed. It's a free download with that number off the PubMed site. But that's some of the hassle that we go through sometimes. Now, let's talk about eucalyptus oil vapor administration. Now, it turns out Angela Sadlin is one of the docs here at the clinic. She was also a later postdoc of mine, but it happened in a peculiar way. She was a med student haunting another doctor's office trying to see what life in a medical office was really like, and the other doctor liked her but was driven a little bit bananas about her enthusiasm and called me up and said, "Have you got anything she could do?" And I said, "Well, I can come up with a project for her." "Great, she's coming over." So I asked her, I said, "I've been very taken by a recent report that showed that some cases of tuberculosis were completely cured by inhaling eucalyptus oil vapor." I said, "Would you just go out and find out if anybody knows anything else about this and what it does?" Thinking that there might be some other stuff out there. Well, she came back with, like this. And in no time at all, what I had thought was a tiny project turned into a mushroom cloud. And remember, she was in the final days of her 4th year, about to graduate. So she did a lot of work on putting it all together, but it wasn't in any shape to publish at all. And the end of the year came, and whoever my real postdoc was ending, and I was supposed to choose another one, which involved interviewing about 40 medical students for the first time and then a smaller number for the second time and making a selection. And I was also ill at the time. And I thought, I am never going to get through these interviews alive. And so I turned to Angela and I said, "Would you like to be the postdoc next year?" And she said, "Yes." I said, "Fine, you got the job. Finish the paper." So what happened is that she located, there were actually research reports showing studies on 30 different organisms, virus, fungi, bacteria, and in 18 of the cases, eucalyptus oil marvelously affected them. Now, that's all been published. There it is. But one of the things that it does, of course, is it actually loosens mucus. It increases the ciliary action, the microscopic hairs along the lining of the respiratory tract to throw it out. And it also seems to stimulate some immune system, and it kills some bugs along the way. So it seems to be a good thing to also give to people with COPD. Now, grandmother used to do this. She had a bowl of boiling water. She put a little bit of eucalyptus oil and put the towel over your head and inhale the vapor. Works wonderfully if you're careful not to boil your face in the process. So I thought, well, is there some way to avoid it? Okay, that's one of these electric cup heaters about that big. That's a dry cup. You just put it on there. You let it warm up. You put a couple of drops of eucalyptus oil in there and breathe it in. That way, no boiling water, no risk of your face being seared or anything like that. So that's how it's done. Now, naturally, mercantilism gets into life wherever it can. This is a product which is downstairs in the dispensary, and I use it all the time, but naturally it costs more than a few drops of eucalyptus oil. It turns out these are pearls of highly enriched eucalyptus oil. In other words, there's one molecule in there called 8-cineol, and instead of it being, as usual, maybe 40-50% of the eucalyptus oil, they've enriched it to where it's 80%. And this stuff is in a pearl which doesn't open until it's in the small intestine. You absorb it, it comes out in the lungs and does its magic. And so that's something that if you don't want to carry around a cup heater with you, one can take this stuff 3 times a day and come out well. Now, this is supposed to say exacerbations of COPD or the symptom intensification. The chronic and progressive course is frequently aggravated by these temporary intensifications. They aren't really understood, but a theory was recently proposed. Now see, you have a complex bacterial variety in the respiratory tract, and various factors determine the balance of varieties, and they can change dramatically in COPD, and they're even more in exacerbations. What they think is that the exacerbations may be respiratory bacterial imbalances with negative effects on the person, and the imbalance changes the immune response. You get bugs, your immune system tries to go after them. If they happen to be deep in the lungs and the immune system goes after them, maybe you will get some lung damage. We think so. So that situation can make things a little worse. And this might explain the so-called frequent exacerbator. I mean, some of these people get exacerbations a lot more often. So this is an area which is being looked at, but we don't have much news about it. Now, very briefly, pulmonary fibrosis. This won't be very long at all. It's more serious than COPD. It's literally scarring of the lungs. In contrast to COPD, this is a problem of proliferation, that is, the proliferation of scar tissue. It's excess fibrous tissue, thickening walls, destroying architecture, and frequently there is perpetual shortness of breath if this is throughout the lungs. Now, the cause may be determined for some, in others it's not, hence the term idiopathic pulmonary fibrosis. Now, in med school we made great fun of this word, saying that it meant that idiots did it, but actually it comes from the Greek meaning nobody knows why it's there. There seems no cure for the scars and damage in the lung because, you know, you can't remove the scar and you can't repair the tissue. But, see, if we go again and say, well, if this is normal tissue with reasonable size bronchioles and there's all the alveoli, in the case of the pulmonary fibrosis, you're seeing destruction of the alveoli, but you're seeing filling in all of this scar tissue, which did not happen in COPD. So this is the proliferation of the material. Yes, they get shortness of breath, dry hacking cough, a lot of fatigue and weakness, sometimes chest pain, sometimes quite far-reaching a problem. So it's a progressive condition. In some of them, if you listen to the stethoscope, you can hear inspiratory crackles. The reason that I started was just hearing inspiratory crackles doesn't necessarily mean that you've got pulmonary fibrosis. I mean, people with infections, you can hear those too, but if they're there all the time, that makes you worry. Diagnosis is usually by high-resolution CT scan. Now, the treatment. Okay, while the process of scarring is understood, the ultimate cause of setting off the scarring is not really understood. Less inflammation, even though there is some, is observed here than is in COPD. So here was a 2005 study using a fair-sized dose of NAC 3 times a day, and they claimed, this is a very good paper, I've read it, that they got better lung function for a year. Second study in 2014 said it didn't. Now, sadly, they didn't try breathing it on the lungs. This was orally. So I wish somebody would do this because it would be an easier thing to use NAC than it is glutathione. Now, some combination pharmaceutical agents have promise, but it's proved to be very difficult to arrest. It's, you know, it's this scarring deal. There's no real way to reverse that quickly. Now, that's about the end of everything that I wanted to talk about, so now you get free access to the physician if you want.